My name is Suzanne Nsur Shaker, or Shaker. Both pronunciations are correct. I'm a medical officer with the MedDRA MSSO, and I'll be the instructor for this webinar. Joining me is my colleague, Hannah Eaton. Hannah is an MSSO training coordinator, and she will kindly facilitate our session today. So this webinar offers an interactive session in the second half where you'll use the Poll Everywhere tool to do some hands-on exercises. At this time, I will ask you to please access the Poll EV using the QR code you see on the screen, and we can start with a few questions to get to know you a little bit better. You can access the tool also by typing the URL in your browser. You don't need to enter a username if prompted, as the polls are anonymized, and you'll be able to see the QR code on the top right corner of the screen if you still need it. All right, so the first question is, where are you joining us from today? And as we wait for the pins to appear on the map, just a reminder that this webinar is scheduled for 2 hours. It's focused on advanced coding. In the MSSO training curriculum, this course follows after MedDRA Coding Basics. So if you haven't had the chance to attend any of the Coding Basics webinars, please feel free to register for an upcoming one or watch one of the recorded sessions on our YouTube channel. And I'm very happy to see folks joining from different parts of the globe today. I do appreciate you taking the time to join us, whether it's early in the day or late in the day for you. Thank you for joining. Okay, just for the interest of time, I do want to keep moving, but I'm very happy to see that the tool has been successfully accessed by many folks on the line. The second question is, how experienced are you with MedDRA? Okay, so I see many folks are relatively new to MedDRA, but I do also see experienced coders with us, so welcome everyone. And the third question is, what primary role or roles do you perform? So please feel free to select as many as apply to you, whether in this current role or in previous lives. It's always interesting to me, and I'm curious to see the section of the industry we have today. So I do see, as usual, the majority are from pharmacovigilance, but we do have a good representation of diverse folks from different parts of the industry. So welcome, everyone. All right, so for the interest of time, we're just going to keep moving. As many of you are aware, MedDRA has been developed by the ICH in the 1990s. The activities of my team, the MedDRA Maintenance and Support Services organization, is overseen by the ICH MedDRA Steering Committee, which in turn is composed of different colleagues from both regulatory bodies as well as industry bodies from different sections of the globe, in addition to the WHO as observer. This is our disclaimer and copyright notice. Just as MedDRA is owned by the ICH, the slides we are presenting are also owned and copyright protected to the ICH. You are welcome to use the information presented. The slides are made available to you. However, please do not use the MedDRA and ICH logos, and if any changes are made, please clearly demarcate them and avoid any inference that they have been endorsed by the ICH. The second bullet point is our disclaimer, and the third is not applicable because we don't have third-party material. So in today's course, we will discuss advanced principles from the ICH endorsed guide titled the MedDRA Term Selection Points to Consider document, as well as the MedDRA concept descriptions. And we'll offer different examples on the use of these concept descriptions and principles in coding. And then we'll show the application for hands-on exercises in the second half of the session and end up with some coding pros and open it up for Q&A. But if you have questions as we go through, please feel free to post them in the chat, and Hannah will bring them to my attention. So let's start with the document that is the main topic of our presentation today. This is an ICH endorsed guideline, and it was created to support MedDRA users via the ICH. So the ICH has provided this guideline to provide advice for industry and regulatory purposes on term selection or coding with MedDRA. So when we say coding with MedDRA, we do mean that you are selecting a term that already exists in MedDRA. So you are selecting a lowest level term or an LLT that is the closest match to your source verbatim. The ultimate objective of these pointers or guidelines is to achieve accuracy and consistency in coding. And it's highly recommended that this ICH endorsed guideline is used as a starting point when creating your own organization-specific coding conventions. This ICH endorsed guide was developed by the ICH M1 PTC working group because MedDRA is an M1 ICH guideline, and that working group consists of representatives of ICH regulatory as well as industry members in addition to the WHO. This PTC working group updates the guide in step with every March release of the MedDRA dictionary, and it's provided in a complete version in 6 main languages and in condensed versions in other supported MedDRA languages, and of course available to you on our website and the JMO website, the JMO being the Japanese maintenance organization responsible for MedDRA in Japanese. This ICH endorsed guideline is really a great resource because it addresses many different types of scenarios you come across when you're coding or when you're reviewing coding or when you're deciding on coding decisions. There are too many scenarios to cover in their entirety today, but we'll touch base on quite a good number. And on your screen, you can see examples of these scenarios in section 3 of the PTC, the points to consider document. You see, for example, age versus event specificity, location versus the organism-specific infection. And there are more examples on the next slide. So you'll see medication errors, no address event, device term, and so on. I do strongly advise you to review the document when you come across a verbatim that you found challenging. You may find the exact scenario relevant to you in this document. And before we move further, I do want to show you where you can find it. So let me just go to our homepage. So this is the meddra.org website. And there are 2 ways that you can access the documents. There's a quick link on the top right corner. So you'll see PTC standing for points to consider. If you click that, it's going to open up a blue ribbon. It will default open. This blue ribbon houses the ICH endorsed guidelines. So you'll see the points to consider in different formats, the PDF, the Word document. It even has a red line version to show changes from previous release. There's a second ICH endorsed guide called Data Retrieval and Presentation. So it's relevant to MedDRA data analysis. And then you have the companion document. And the companion document is really a great resource for topics like medication errors, manufacturing, quality system issues, product quality issues, and so on. So let me go back to the slides and get started with the principles. So we're going to start with a few general principles on coding that we typically cover in more detail in our basic coding webinar. Starting with when you code in MedDRA, basically what you're doing is you're selecting a current lowest level term, LLT, and you're trying to find the one that is the closest to the natural language term or the verbatim in the source of the report. So for example, for a verbatim that says abscess on face, it's not really enough to code simply to abscess because there are different types of abscess with different locations, and some of these location-specific terms do exist in MedDRA, like brain abscess, lung abscess, neck abscess. Now, of course, when you look for these LLTs in MedDRA, it's best to use word stems. So in this example, if you look for abscess and you look for face, you're not going to find that in MedDRA. But if you use a stem word like FAC instead of face, you're going to find the facial abscess. And an important reminder, never use non-current LLTs for coding. Non-current LLTs exist in the MedDRA browser. They are housed in a red box. They are intended for legacy conversion purposes and historical review purposes, but they are not meant to be used for coding. Okay, another general example is to code all the reported information. So if you receive information from the reporter, which you don't code, then you won't be able to retrieve it. You won't be able to use it in your data analysis. You should try your best, of course, to find LLTs in MedDRA that capture as much of the source details in a single LLT term as possible. But in some cases, a single LLT will not capture all the information you're receiving. And in those kind of situations, you may need to select more than one single LLT. Now, having said that, we should also remind you that in certain forms, like the AE forms, if you do select more than one coding term for the same verbatim, this could lead to redundancy in your computed counts, basically increasing the number of AEs. So there needs to be an internal discussion about what your practical approach will be, and each specific organization should document in their coding conventions how they approach these scenarios. I'm sure there are some users with us today who are working in databases that allow the selection of more than one LLT per verbatim, and others that work in databases where it's a one-to-one correlation. So please have that kind of internal consultation if you're not sure about the organization's approach. If you currently do not have an organization-specific guidance, one good practice would be to consult the PTC document and then have an internal discussion with the respective stakeholders. Maybe have a call with the coding group and include folks in data management, folks who deal with data review and analysis, and then document the procedures and approaches. Of course, ensure everyone is trained and follow them consistently. So here's an example from the PTC document. Metastatic gingival cancer. In MedDRA, there's not a single LLT that captures the specificity of the site of gingival cancer, plus the fact that this is a metastatic carcinoma. And if we try to populate MedDRA to ensure that it has all different types of metastatic spread for all different types of carcinomas, it will greatly overpopulate MedDRA. So this is why not all options are available there. So in this scenario, coders do have the option to either code to both LLTs or to pick just one LLT and document their approach. And the most important thing is to apply this approach consistently. So consistency is key in coding. Another principle is get into the habit of checking the hierarchy. So MedDRA has 5 layers of hierarchy. You start with the lowest level term, which is the term that you use for coding. And then you have preferred term. And the preferred term is a very important layer in MedDRA because that's the one typically used for reporting purposes and analysis purposes. And then we start to see grouping terms like the high level term, the HLT, the high level group term, the HLGT, and finally the system organ class or the SOC. When you're coding, it's always good practice to take a look at the LLT you're considering and then follow it through its hierarchy to the system organ class, just to make sure that you are in the right area, that it makes sense to you. So for example, you're coding low energy. If you don't see an exact match in MedDRA and you decide to select the LLT worn out, following that hierarchy to its preferred term fatigue will satisfy you that maybe this was a good choice. But I do want to show you a different one in the browser. So let me just go back to our home page, and there are 2 browsers currently available to you. They are temporary credentials also provided by Hannah in the chat. You are welcome also to use your own organization-specific credentials if you'd like to click along. But there are 2 browsers available to you. The first one is the legacy browser that has been there for a while. It's accessed via the quick link on the top. So under WBB on the top, if you click that, it's going to take you to our web-based browser. For some reason, my screen is frozen. Okay, let me try again. Hannah, can you see the screen?
Yes, I'm seeing the website now.
Okay, thank you. So that was, I don't know why that one froze, but so this is our website. And if I click on the quick link WBB, it takes me to the legacy browser and I can log in directly in there, but there's a second browser, which is the new web-based browser. And to access that, you go under How to Use and Tools. So if you click on the big selection How to Use, you go down to Tools. And in the right-hand corner here, you see different links of different tools that we have. You have another link to the web-based browser that we just accessed, and you have a link to the new web-based browser. And if we click on that, we access the new web-based browser. So you'll see a little bit of a difference in the interface. The new browser is a much more simplified interface focused on the search functionality within the MedDRA browser. It has all the same tools as in the legacy browser. So I just wanted to show you something, and maybe we can use the legacy browser for this demo. Cervical. If I click cervical and I look up all the different options for the result, to know if I'm selecting the appropriate LLT that matches my source verbatim, I do need to follow the hierarchy. And to follow the hierarchy, there are different ways. I can either follow the pluses and just move up the hierarchy from the LLT to the PT to the HLT to the HLGLT and to the SOC, or I can just click on the term and it opens up the right hand view, the right hand section, which shows us the hierarchy. Or I can right click on the term and go to browser. And when I go to browser, it takes me directly into the hierarchy for that term within that system organ class. So there are multiple ways to check your hierarchy. But the reason I picked cervical is because cervical could relate to the neck, or it could relate to the cervix. And for me to identify if I'm picking the right one, so let's say acute cervical pain, if I'm not sure which one this relates to, I can just expand the hierarchy and I'll see that this talks about neck pain. But for example, cervical abrasion, if I expand the hierarchy, I can see this actually goes to the reproductive system organ class. So this is not neck, this one is the cervix. And that's why it's very important to follow the hierarchy when you're picking terms in MedDRA, just to make sure that you are on the right one. So let's go back to the general principles. Another tool that is available to you to ensure consistency are the concept descriptions. So concept descriptions basically are a description of how terms are represented in MedDRA. They are not definitions because MedDRA does not include definitions, but these descriptions speak to the use of medical concepts within MedDRA. They clarify how a medical concept is interpreted, how it's used, how it's classified from MedDRA's perspective. And that's important in an international standard like MedDRA because medical practice could differ in different regions of the world. And these concept descriptions are easily accessed directly from the browser. So I want to show you what they look like. This is an overview of what they look like, but I do want to show you how to get to them. So let me take you back to the browser. So this is the legacy browser. Let me just restore defaults. In the legacy browser, you access the MedDRA concept descriptions on the top panel. So the top panel has these tools available to you, and the first blue option is the concept descriptions. So if I click on them, it shows me the concept descriptions. They're alphabetized and they're limited. There's under 90 of them. There's 80 some concept descriptions, but they represent things that are important to understand how they're being used in MedDRA. So for example, if we go M, we'll see medication error. So medication error is described for the purposes of use in MedDRA. You'll see under O, off-label use. You'll see overdose. Like for overdose, it is the use of more than the maximum recommended dose. So that explains how this concept is being used for purposes of coding in MedDRA. In the new web-based browser, so here's the new web-based browser, I'm going to use settings. I'm going to just restore the default settings so that when you open the new browser, you'll see the same view as I'm looking at. And under settings, again, you're looking for documentation. So if you expand documentation, here's our MedDRA concept descriptions. If I click that box, it will open up an icon that looks kind of like a first aid box with the plus sign on it. And these are the concept descriptions, the same ones that I was just viewing from the legacy browser. So I do advise you that please take the time to skim these through. Like I said, there's not that many of them. It's 80 some, maybe under 90 of them. So it will be a quick read. And especially if you're dealing with a concept that may be understood differently in different parts of the world, take a look here to see if it's represented. All right, so let me go back to the slides. And before we go into certain advanced principles, any questions so far, Hannah?
We've had 2 questions come in. The first one asks, are there any differences between the legacy and the new web-based browser apart from the enhanced search functionality?
There are minor differences. The functionalities are the same in both. So whatever the older browser allowed you to do, the new browser allows you to do. And there are attempts to enhance a few things. So for example, the older browser, if you put in a search function that produces too many results, it would give you kind of a yellow message saying, I just can't show you everything because there's too many results. The new browser overcomes that and does in fact show you, even if they're in thousands. So minor differences, but the functionalities are all the same. And I do advise you to try the new browser because eventually the old browser will be retired. I mean, the new browser is the new improved version, so eventually it will be retired. If you're still using the legacy browser, I do advise you to start using the new one. And I do believe we have recorded sessions on our YouTube with demos of the new browser. Any other questions?
Perfect. The next question asks, if a patient has any concurrent conditions and post starting a drug, these concurrent conditions get worse, how do you code that worsening as an event?
All right, so this is a good example of, let's look at, let me take you to that points to consider, right? So you have a question about a certain scenario. Does that scenario exist in the PTC guideline? So you go to the PTC guideline and you open up the points to consider document, and here's your table of contents. So is there a worsening, or I'm not even sure if it exists, but I wanted to try it out. So let's say worsen. Okay, so modification of pre-existing conditions. I think that was the question, right? So pre-existing conditions that have changed may be considered adverse events, especially if they worsened or progressed. And in terms of choosing the appropriate LLT, if the LLT exists for aggravation or exacerbation or worsening, you can select that LLT. But if an LLT does not exist for that, and it gives you an example, then you select a term for the pre-existing condition, and you have the option. You have the option of selecting condition aggravated as a second LLT. So I'm glad that that question was raised, because this is a real life example of how this PTC guideline can give you recommended approaches. Now remember, it's a points to consider. It's not mandated. And they do realize that different organizations may have different preferences, which is fine. And that's where your organization-specific coding guidelines will come in handy. And you can document your specific organization preference for these kind of scenarios, ensure everyone is aware and trained so that you have consistency. Because again, consistency is always key. So just because there's an option available in the PTC does not mandate that you use it. It just gives you the different options available to you. And sometimes it has a preferred option. Even preferred options are not mandated. So I'm glad you raised that question. Anything else before we move on, Hannah?
No other questions at the moment.
Okay, great. So let's go over some advanced principles now in coding. And let's start with something that is a common scenario. Sometimes you have a diagnosis provided to you that is provisional. And when we say provisional, we mean that the reporter will tell you things like, this is a suspicion of, or they can use words like probable, presumed, likely. They can use even words like rule out or differential. So those are considered provisional diagnosis. And the PTC guideline has a very nice section about how to deal with a diagnosis versus a provisional diagnosis. So right off the bat, if you have a diagnosis, you have MI, myocardial infarction, as your reported term. Of course, you're going to code this to myocardial infarction, whether it's a singular diagnosis or multiple. So the same rule applies. If you have a provisional diagnosis and your reporter said this was a possible myocardial infarction, and that's the only information you currently have, the only option to you is to code the myocardial infarction. So you don't have any other information. And of course, many organizations will be seeking out further details or further confirmation with the reporter. So what happens if you have signs and symptoms? So in the event that you do have signs and symptoms associated with a definitive diagnosis, the preferred option, according to the PTC guidelines, is only code the diagnosis, of course, as long as the signs and symptoms are associated with the diagnosis. So for example, you have anaphylactic reaction, and they reported the signs and symptoms. They have rash, dyspnea, which is shortness of breath, hypotension, and laryngospasm, which is when your throat closes up and you can't breathe. All of these happen in anaphylactic reactions. So here on the left-hand side of the screen, the preferred option is to only code the diagnosis, because these are all signs and symptoms that match the diagnosis and it's a single event. But if the reporter tells you that the diagnosis is not confirmed, it's provisional, they suspect that there was a myocardial infarction, they are suspicious of it, but it hasn't been confirmed. So you know that the reporter is not sure about the diagnosis, but they're providing you the signs and symptoms. They say that the patient presented with chest pain, dyspnea, diaphoresis, the sweating, but they're not 100% sure yet that the diagnosis was myocardial infarction. So they provide you with the qualifier that this was possible myocardial infarction. In this kind of scenario, the preferred option, again, according to the PTC guideline, is to select MedDRA LLT terms for everything, for the diagnosis and for the LLTs that represent the reported signs and symptoms. But there is an alternative option that the PTC guideline also gives you. So you have the option to select that preferred option, but there's another way to look at this. Another way to do it is that if you have a definitive diagnosis with signs and symptoms, you can't code everything. And there are different organizations, many in fact, that choose that option of coding everything. But when you have a provisional diagnosis with signs and symptoms, so it's a possible MI, and they presented with chest pain, dyspnea, and diaphoresis, the alternative option, if you don't want to code everything, is code what you're sure of. You're sure of the signs and symptoms because these were the presentations of the patient. So you're sure they had chest pain and dyspnea and diaphoresis. You're not sure about the myocardial infarction. So in this case, the alternate approach is you code the signs and symptoms, but you don't code the provisional diagnosis. That's the alternate approach. And the rationale behind this is that there is a chance that the provisional diagnosis may change, but the signs and symptoms will not. And of course, this principle applies whether it's a single diagnosis, single provisional diagnosis, multiple diagnoses, or multiple provisional diagnoses. But one important thing to always remember is that in any of these scenarios, if you receive signs and symptoms not associated with the diagnosis or not associated with the provisional diagnosis, please remember to code these signs and symptoms that are odd, that don't belong, because there could be another pathology completely different that's going on with the patient, and you don't want to miss that. So in this example, and it's a simple example, that if you had the myocardial infarction, you had the chest pain and the dyspnea and the diaphoresis and the ECG changes, but you also had jaundice. Jaundice is not a typical sign or symptom associated with myocardial infarction. And in this case, whatever option you decide to follow from the PTC guideline, the jaundice needs to be coded because that's not typical for the myocardial infarction, and you don't want to miss that. So I hope that's clear. Let's show an example, and then if anybody has questions, please we're happy to address them. So here's an example. The reporter said there was a sepsis leading to shock, and the underlying pathology is provisional. It could have been a possible spontaneous bacterial peritonitis or a bowel perforation. When you're thinking about how do I code this, following the preferred option in the PTC guidelines, the preferred option was for provisional diagnosis as well as signs and symptoms is you code everything. So in this example, I do want to code the sepsis. I do want to code the shock. I want to code the possible spontaneous bacterial peritonitis and the possible bowel perforation. But I want to select as few LLTs as possible. And I do know that in MedDRA, there is a combination term for septic shock. So in this particular example, the best option is to select an LLT for septic shock, as well as LLTs for the 2 provisional diagnoses that have been provided by the reporter. And that way we capture everything. We don't lose any significant bits of information. Does anybody have any questions about that? Do we have questions, Hannah?
I am not seeing any questions come in at the moment.
Okay, great. I'm sure we'll have questions later if somebody wants to come back to this point. All right, let's talk about conflicting or ambiguous information. And of course, these are challenging to code because it's not always clear what is intended by the reporter. When this occurs, always attempt to obtain more specific information if you can. Now, if clarification cannot be achieved, the PTC guideline does offer insight how to approach these kind of scenarios. So, for example, you have the first report saying hyperkalemia with a serum potassium of 1.6 milliequivalent per liter. And if you look up the normal range for serum potassium in milliequivalent per liter, it's going to be anywhere between maybe 3.5, maybe up to 5, maybe 5 point something. But 1.6 seems low for serum potassium in the units of milliequivalents per liter, and yet the reporter said hyperkalemia. So it looks to be discrepant. It looks to be that one of these 2 parts of this report does not match the other. And if you're not sure what to do in this case and you're not able to query for clarification, your best option is to select an LLT for a serum potassium abnormal, because it's either going to be the first part that's correct or it's either going to be the second part that's correct. So the serum potassium abnormal just specifies that there's something going on with the potassium. You're not sure if it's hyper or if it's hypo. The second is a vague, ambiguous abbreviation. And in MedDRA, there was an activity where many of the vague or ambiguous abbreviations have been made non-current. And GU is one of them. GU could either be genitourinary or it could be gastric ulcer. So it is an ambiguous abbreviation, but you have the pain. So you have something going on that's painful. You know the subject is experiencing pain, you're just not sure what kind of pain it is. So in this kind of scenario, you can code the pain. Sometimes the information is too vague to even know anything about it. So turned green is a kind of vague information where you're not even sure if it's talking about the patient or something outside of the patient, like maybe the pill turned green or the liquid turned green. So in this kind of scenario where you're not even sure if it is a patient condition that's being reported, the best option is the LLT unevaluable event. You know, something happened, so an event happened. You just don't know if it is related to the patient as a disorder or something outside of the patient. So unevaluable event will cover that kind of scenario. If you do know that something happened to the patient, it was a medical disorder, you just don't know what it was. So the reporter said the patient had a medical problem, just not sure what it was. Then the best LLT would be ill-defined disorder, because it has disorder in it. So you know that this has some kind of medical issue with the patient, but you don't know what the specifics are. Here's examples. So your first report says clinical complication of IUD. And if you know, you're looking in MedDRA, you're going to see IUD complication. It's a complication associated with the device. So you know that in MedDRA, that IUD complication talks about an intrauterine device. But if you work in pregnancies and pregnancy health, you might think of IUD as intrauterine death. So the IUD itself may be ambiguous. And if all the source you have says clinical complication of IUD, then your best bet is unevaluable event, because you don't want to make the assumption of what that IUD acronym stands for. Your second example, you have a hypoglycemia, but this time the blood glucose is 200 milligrams per deciliter. And in that unit, that's high because, you know, random blood glucose typically falls under 140 milligram per deciliter. So it's a discrepant information. You know something's going on with the glucose, but you don't know if it's hypoglycemia or if it's in fact increased. So in this example, your best bet is blood glucose abnormal. Now, talking about blood glucose and increase or decrease, sometimes you have medical conditions reported and sometimes you have investigation results. So in MedDRA, the SOC investigations, it includes test names with qualifiers like increased, decreased, normal, abnormal, and those without qualifiers, because you want to be able to code all types of investigations being ordered for the patient. Corresponding medical conditions like hyper and hypo, they tend to exist in disorder system organ classes, like metabolism and nutrition disorders. So your selection of an LLT is going to impact your system organ class. And it's very important to understand that, because folks who are doing the data retrieval and data analysis usually summarize by system organ classes. So let's take a look at this first example. The first example is hypoglycemia. If you code it to hypoglycemia, you're coding it as a disorder. It goes to the metabolism and nutrition disorders. If all your coding is decreased glucose, that's an investigation result. So it goes to the system organ class of investigations. And so it's important when you have a report that comes in and it's giving you information to decide, are you coding the disorder or are you coding the investigation? Sometimes you have ambiguous investigation results and sometimes it's unambiguous. So if your investigation results provides you with a numeric qualifier, MedDRA does not have numeric qualifiers. So it's an important thing to have a reference, maybe a lab reference, maybe a universal one like Harrison if you like that one, or Oxford if you prefer that one, or if you have your own assigned for your trial, you can have a lab reference. So a glucose of 40 milligrams per deciliter. In milligrams per deciliter, the normal blood glucose tends to be anywhere from 70 to 100, maybe just under 100. So in glucose 40 milligram per deciliter, this tends to be low. So if you select a glucose low as an LLT, you're correct because you have the units clear and glucose is clearly below the reference range. But if you don't have the lab units and all they reported was glucose was 40, then you have a problem, because glucose in different areas of the world in different labs could have different lab units. So it's not just in milligrams per deciliter, you also have millimoles per liter. And the glucose range in millimoles per liter is a lower one. It's between 5 and 7. So if your lab result was in millimoles per liter, this is actually very high. So when you have an ambiguous lab result reported and you're not 100% sure what the range was, what the reference range was, and you don't want to make assumptions, you can select an LLT that says, for example, glucose abnormal, because you don't want to make an assumption unless you have the ability to query the reporter for more detailed information. Well, how do you handle it when there's an investigation and a diagnosis? And we've seen a couple already, right? So when investigation results are reported with a diagnosis, per the PTC guideline, you only need to select a term for the diagnosis so long as the investigation result is consistent with that diagnosis, kind of similar to the signs and symptoms. So if you have an elevated potassium and the potassium level is 7 millimole per liter, and you have a hyperkalemia, so you don't need to separate these into separate LLTs. An LLT of hyperkalemia for the diagnosis is sufficient because an elevated potassium is consistent with that diagnosis. In certain situations, you have grouped investigation results reported as a single report. So in the example you see, you have increased alkaline phosphatase, increased SGPT, SGOT, and LDH. All of these different lab results are provided to you. In the PTC guidance document, the recommendation here is to select an LLT for every single one of these lab results separately, and to avoid lumping them together as, for example, liver function test abnormal. So they do recommend you avoid the lumping together, because every single one of these may be significant in its own regard. So the LLT selected in this case would be alkaline phosphatase increased, SGPT increased, SGOT increased, and LDH increased. So let's have an example and then we'll stop for questions. All right, so you have an example here of a result that says there were increased serum creatinine and BUN and increased BUN creatinine ratio. Based on what we just said as the recommended approach in the PTC guideline, your best selection here is to select LLTs for every single one of these separately. So you're coding the increased serum creatinine, you're coding the BUN increased, and you're coding the blood urea nitrogen creatinine ratio increased. You avoid lumping them together as abnormal function tests. How about the second one? Patient had features of aldosterone excess. This is a tricky one because in the reporter words, they're talking about the patient. The patient had features of aldosterone excess. So you may be tempted to think that this was a lab result, but it's not really a lab result. In this particular report, the reporter is conveying to you something about the patient themselves. So there was a clinical occurrence with the patient that showed features of aldosterone excess. In this example, the best option will be aldosteronism, because it describes a medical condition in the patient rather than a single lab result. Any questions at this point, Hannah?
Yes, we've had two questions come in. The first one asks, for those organizations that code outcomes as SAEs, how to code such scenario as a patient was hospitalized and later died due to an unknown cause?
Okay, so we'll be talking about those kind of outcomes coming up. So hold on to that question. Any other questions at this time?
Our next question asks, what parameters are used to determine whether or not to code the complication of an event separately?
That's a good question, and they are also in the PTC guidelines. So, for example, if you have a medication error with sequelae, those kind of examples have a clinical complication arising from a procedure or arising from a medication error. Those are also topics that we'll be touching on in coming slides, so hold on to that as well. And once we touch on those topics, if it didn't answer your question, please come back to us. All right, let's talk about combination terms. So combination term in MedDRA is a single medical concept combined with additional medical wording that provides important information either on pathophysiology or etiology. It needs to be an internationally recognized, distinct, and robust medical concept to be accepted as a combination term in MedDRA. So the example for us is in the second part of the slide, diabetic retinopathy. Diabetic retinopathy is a combination term that has multiple information associated with it. Now, a combination term may be selected for certain reported events, like a condition due to another condition, as long as we have it in MedDRA. So if two conditions or concepts are reported in combination and a single MedDRA combination term is available, we can select that. But sometimes it is a single medical condition. There's no need for a combination, like arrhythmia due to atrial fibrillation. Every atrial fibrillation is an arrhythmia. So if you split these up into atrial fibrillation and arrhythmia, you're double counting your event without adding any significant information. You've already captured the atrial fibrillation, which in itself is an arrhythmia. Same for hepatic function disorder specified as acute hepatitis. If you just code the acute hepatitis, that acute hepatitis is in itself a hepatic function disorder. So you don't need to split these kind of terms. The combination terms that exist in MedDRA are ones that give you a bit of more details within the same term. Like retinopathy due to diabetes, you may want to look for your STEM words, for example, DIAB for diabetic or diabetes, and retinopathy. You might be able to find diabetic retinopathy. You'll be able to find itchy rash. You'll be able to find HER2-positive breast cancer. Not every cancer in MedDRA with every type of subtype of cancer is available in MedDRA, but there are prominent ones available. So when you receive your source report and it has what seems to be a combination term, take a look in MedDRA to see if you can find a combination or not. However, if splitting a term provides more clinical information, that's when you need to think about selecting more than one LLT. So for example, diarrhea and vomiting, you don't have a diagnosis in this case. You have these two symptoms that the patient had diarrhea and the patient had vomiting. You do need to split them up to capture the full spectrum of what's being reported. Risk factor due to fall. So the fact that the patient fell may be important. It may actually be related to your product if it caused the patient dizziness or feeling drowsiness or something like that. So you do need to capture all the information being reported. The BRAF positive malignant melanoma, it's not a combination in MedDRA. So in this case, you do want to capture the actual oncology itself and the BRAF, the gene mutation as well. Of course, medical judgment is important in these kind of scenarios because when to split and when not to split may rely on your understanding of is there additional clinical information that will be crucial or significant if we do split. Here's an example. So the reporter says there's retinal disease from HIV with near total blindness in right and left eyes. If you look through MedDRA, you'll find retinal damage. You'll also find retinal disorder. You'll also find HIV disease. But there is also in MedDRA an HIV retinopathy. So you're able to actually select a single LLT to convey that the retinopathy resulted from the HIV. And that would be a better approach than splitting them up into separate HIV disease and retinal disorder. But what about the near total blindness? Now, blindness is not typical in HIV retinopathy. It can become a complication that arises from HIV retinopathy. So it's also, in this case, recommended to capture that separately. So for this particular report, the best approach is to capture an LLT for HIV retinopathy because it gives you the HIV and gives you the retinopathy in a single LLT, but also to capture the blindness both eyes because it's not a classical sign or symptom of HIV retinopathy. Let's talk about medication errors. Medication errors is a very important concept, and it's actually so important it has its own webinar. So we do offer webinars specific to medication errors. You're welcome to check them out on our schedule or on our YouTube channel. And MedDRA concept description does talk about medication errors because they are an important concept to understand internationally. So for purposes of term selection in MedDRA, a medication error is defined as an unintended, so it's not intentional, and it's preventable. And that's why they're so important to regulators to be reported. If they are preventable, that means you can take action so that they don't happen again in the future. And of course, they may lead to inappropriate medication use or patient harm. So they don't always have sequelae, but they may lead to sequelae. And another important part here is that they occurred while the medication was in the control, either of the HCP professional or the patient or the consumer. So during that part of the medication use cycle. And PTC guidelines gives you different scenarios of how to code these. And I think this ties into the earlier question of when do you code the clinical sequelae? So if a medication error happens and there was a clinical sequence reported for that, the PTC guideline does tell you that it's important to capture both. It's important to capture the medication error itself, as well as the clinical consequence that happened to the patient. And be as specific as possible in your medication error, because although we have the LLT medication error in MedDRA, it's not specific enough, and it's not going to be the best use when you're doing your data analysis. You do want to be as specific as possible. So first example, the patient was administered the wrong drug and experienced hypotension. So the clinical sequelae is there, it's hypotension, you select an LLT for that. What about the medication error? The patient was administered the wrong drug. So it's important to assign an LLT that the wrong drug was administered. And yes, MedDRA has different grouping terms for the different types of medication errors during the cycle of medication use. And I'm just going to show you that real quick. So let me go back to our browser, and the medication error groupings are under the injury SOC. So if you expand that and you look through the high-level grouping term of medication errors and product use errors and issues, you're going to see different subgroupings or different HLTs that speak to the different cycles of medication or product use. So here's your administration errors. Here's your dispensing errors, monitoring errors, preparation errors, prescribing errors. So when you receive a report from your source and they talk about a specific cycle where the medication error happened, you can expand the relative HLT and see if you find the best matching PT for that. That's an easier way for you to look for terms when you're coding medication errors. Let's look at the second example here. Because of similar sounding drug names, the wrong drug was dispensed, and as a result, the patient took the wrong drug and experienced a rash. So in this example, not only was there a clinical sequelae of a rash, but there was a story of how this whole thing happened. It started with similar sounding drug names. That's a contributing factor. That's also important to capture, because that's a good hint to you that if you see that in your report, there's an action here that's possible to avoid any injuries to the patient in the future. So similar sounding drug names does have a LLT in MedDRA for drug names sound alike. That led to your originating error, which was that the wrong drug was dispensed. So there's a first medication error of the wrong drug being dispensed. That's a dispensing error. And a resultant error as well for the patient taking the wrong drug. So the wrong drug being administered. And it's important also to capture that, because in this particular story, the wrong drug reached the patient and the patient took it. So it's important to capture all the information you received from the reporter. You have the contributing factor, you have the originating error of the wrong drug being dispensed, you have an additional or consequent error of the wrong drug being administered, and you have a clinical sequelae of a rash. So in the stories that you receive about medication errors, please take your time to assess exactly how much information that you received and try to capture LLTs that convey the totality of the information. Here's another example. The insulin preparation was given using the wrong syringe. That resulted in the administration of an overdose and the patient developing hypoglycemia. So again, you had a clinical sequelae of hypoglycemia that you're capturing. But how did this happen? So the insulin preparation was given in the wrong syringe. So there was an issue of the drug being administered in the wrong device. That is an option for an LLT in MedDRA. And the story itself, the context of the story itself, tells you that even though an overdose happened, that this was accidental. And it's so important in the PTC guideline to differentiate between intentional overdose and accidental overdose, that in this kind of scenario, even though you don't have the word accidental, if you have the context available to you that clearly shows you this was an accidental overdose, this is an example where the PTC guideline will recommend that you select the specific LLT of accidental overdose based on the context. So the context of the story tells you this was not an intentional overdose. This was clearly accidental, even though the word accidental is not provided to you. This is an example where the PTC guideline tells you go ahead and code it as accidental overdose. What about when you have medication errors, but there's no clinical sequelae? So there are two options available to you. You can code the medication error. It's always important to code it because it happens. You have the option to code no adverse effect, but that's not the preferred option per the PTC guideline because that's a negative. And typically we don't capture negatives in AEs. Having said that, some organizations do have the protocols to actually code whether or not there was an adverse effect, and if there was not, to select an LLT for adverse effect. So please ensure that you have that documented in your internal guidelines if that is important to you. But in this example, the IM formulation given IV instead of IM, but there was no adverse effect. The preferred option for the PTC guideline is just to code what happened, which is the medication error in this example. What about if there was no medication error? So nothing really happened, but there was the possibility of a medication error happening. So you have the contributing factor. So the pharmacist noticed that the names of two drugs look similar. So there is drug name lookalike. The pharmacist was concerned that this may result in someone getting a wrong drug. So they even told you what the potential for the error could have been. But the error didn't happen. Now, in this example, you do want to capture the contributing factor, which is the drug name lookalike, and you also want to capture the potential for the medication error, because there could have this could have happened. And if you know the specific type, that it was a potential for medication error wrong drug, that is the one that you select. So potential errors should be designated as such. This will take you to the LLT and the PT of a circumstance or information capable of leading to medication error. It's going to help you in your analysis to identify areas where actions can be taken to prevent these in the future. And that's why for medication errors that did not happen but could have happened, and you have the details, it's still important to capture LLTs for those, even though nothing happened. So even though in this kind of example, nothing happened, but you have a very important information you want to capture in your analysis. Now, medication errors are a huge topic, and we don't really have the time to go into details. But like we said, there's so many resources available to you. The points to consider document, section 315, is specific to medication errors. The companion document that we showed you in that blue ribbon is a wealth of information on medication error. It has a lot of examples. And like we said, that high-level group term of medication errors within the injury SOC, if you expand that and take a look at it, you're going to see a lot of groupings of HLTs. And then as you expand them, you're going to see all the different PTs available and the LLTs. And of course, concept descriptions are another resource to you when you're trying to code medication errors. And on top of that, we have webinars specific to medication errors. We have in our LMS, our learning management system, the special situations module, which speaks to medication errors. And of course, we have recorded webinars on our YouTube channel that you can access and just review at your leisure. So I want to touch base on overdose, because overdose is one of the topics that is touched on in the PTC guidelines as well. For overdose, poisoning, and toxicity, we code to those terms if they are explicitly reported. So overdose with clinical consequence, you code the overdose and you code the clinical consequence. in this example of stomach upset from study drug overdose, we don't know what kind of overdose it was, whether accidental or intentional, and we don't have the context that guides us to deduct that this was accidental. So we can't select accidental overdose unless we have the context. But sometimes the word overdose is reported and there's no clinical consequence. And just like medication errors, if there's no clinical consequence, we just code what happened, which is the overdose. But you do have a second option in the PTC guideline to those organizations who care about having that specifically coded as no adverse effect. You can code that if it is useful to you and your approach, as long as you document it and be consistent. So here's examples of a few touching base on overdose and medication errors. So the patient's renal function was measured every 6 months instead of monthly as recommended by the label for the drug. So this is a monitoring action. So in drug monitoring, what you do is you survey the parameters which may be affected by the use of a drug. So for example, a common parameter would be liver function test or renal function test or blood cell counts. So you're measuring these parameters to determine whether there are issues with the use of a drug. So in this particular example, they are doing this monitoring activity, but they're not doing it correctly. So it is a medication monitoring error. The first one is not wrong. It's just not the most specific, because they are performing this monitoring procedure. It's just they're not performing it correctly. So in this first example, you do have an LLT that fits the scenario where drug monitoring procedure was done but incorrectly performed. The second example is one where the patient unintentionally took more than the maximum recommended dose due to a dispensing error. So it gives you a bit of information telling you that there was a drug dispensing error leading to the patient unintentionally taking more than the maximum recommended dose. It doesn't have the word overdose in it, but the context is clear that they took it unintentionally, so it's accidental, and they took more than the maximum recommended dose. And I just want to show you again that concept description for overdose. So for purposes of MedDRA coding, an overdose is more than the maximum recommended dose. So even though you don't have the word overdose in your report, this matches the concept description of an overdose. So in this example, you will be correct to code it to accidental overdose and to drug dispensing error, because that's the information you have. This is where we touch about death and hospitalization, going back to the question we had a little bit earlier. Death, disability, and hospitalization, they tend to be outcomes. They don't tend to be adverse events by themselves. They also tend to be serious criteria. Usually in your CRF or your data collection module, usually you have fields that are specific to this kind of information. You may even have a form specific to hospitalization and request the date, the end date, and all of that. They typically don't tend to be adverse reactions or adverse events. However, sometimes they are the only information being reported. If they are the only information being reported, MedDRA does allow you options for coding death and hospitalization. And in certain situations, the death itself gives you important clinical information. So how do we approach these? If you have a death with a cause of death, and the death itself doesn't give you additional important clinical information, you just code the cause of death, because death itself is an outcome. It's a serious criteria. Same for hospitalization. If you have a reason for hospitalization and the fact that they were hospitalized, then you don't need to capture the outcome when you code. But in the example we see with on the slide, the patient experienced a rash and had sudden cardiac death. In this particular example, the sudden cardiac death gives you important clinical information that will not be captured elsewhere. So you do need to capture an LLT for the rash, and in this scenario, an LLT for the sudden cardiac death. But here is an example where it says death from cerebral hemorrhage. Now I have the cause of death, and I know death is an outcome or a serious criteria, so it's being captured somewhere else. And I know that in this particular example, there's no additional clinical information from the death itself. So it is perfectly correct to just capture an LLT for the death, for the cerebral hemorrhage. But in this example, the patient was found dead. That's the only information I have. There's nothing else available to me. So in this particular example, I will look for an LLT that matches the scenario, and I will find the LLT found dead. So MedDRA does have, under the general SOC, a group of terms that allow you to code death and allows you, under the procedure SOC, to code hospitalization as long as you don't have anything else available to you. What about suicide and self-harm? So when you're coding suicide attempts, you need to understand the full extent of what the information is that's coming to you, because if the information provided to you says that the patient completed their suicide attempt, then that's a completed suicide. But if you don't have the information that the outcome of the suicide in your source information, you can't code that as a completed suicide. So for example, a suicide attempt that resulted in death, that's a completed suicide, and death will be captured as an outcome or a serious criteria in its own field. If you have an overdose, you can't assume that the intention behind the overdose was a suicide attempt. So unless the reporter tells you they committed an overdose because they were trying to attempt suicide, you can't code it to a suicide attempt unless you have it in your verbatim. Same with self-harm. So if a patient slit their wrist without telling you that this was a suicide attempt, you cannot assume that this was a suicide attempt, but you do have terms in MedDRA for self-injury or self-harm. So I hope that that's clear. So let's take an example. Deliberately took an overdose. So we do have deliberate overdose in MedDRA. The reporter is not telling us that this deliberate overdose was because they were attempting suicide. So in this example, it's a deliberate overdose. And of course, the word intentional matches the scenario, but we have the word that is closer to the verbatim, so we pick deliberate. Okay, I think drug interactions may be the last main concept, and then we open it up for the hands-on exercises. Drug interactions is another area in MedDRA where it's important clinical information. The challenge with drug interactions is that they need to be reported in the verbatim because people take different things together all the time. So if the reporter tells you that they took 2 different kinds of medications, but they don't specifically tell you there was an interaction, then you can't assume that an interaction happened. But if the reporter states that there was an interaction, those kind of LLTs do exist in MedDRA because we do have interactions drug to drug, drug to food, drug to device, etc. So if the patient drank cranberry juice, which interacted with their anticoagulant drug and caused an INR increased, then you have the ability to code this as a food interaction. But if the reporter does not specifically state that an interaction happened, then just select a term for the reported medical event and don't assume the interaction. So for example, after taking the antihistamine along with her prescription proton pump inhibitor, this patient developed vertigo. Now, the reporter is telling you that she took 2 different kinds of products at the same time, and she developed vertigo. But they're not telling you that an interaction happened. So in this particular example, all you can code is the LLT of vertigo. We don't want to make assumptions. All right, so before we start with the coding exercises, Hannah, let's stop here and ask whether those 2 previous questions have been answered to the satisfaction of the folks, or if they have follow-up questions, or if we have new questions.
I have not seen any follow-up regarding those 2 questions, but we've had lots of new questions come in.
Okay.
Our first one asks, how to decide if lab value is to be coded as an event?
So, I mean, typically when you have a protocol, you do have a definition of an adverse event, and the definition of an adverse event is not restricted to a medical occurrence. So usually, I mean, please do refer back to your source, how you are defining adverse events, but usually any untoward occurrence in a patient, whether that was a medical issue or a lab result, usually get reported as adverse events. But again, I will leave that up to your references that you are using for your data collection. Any other question?
Question says, sometimes it can be difficult to find an appropriate SOC or measure term for certain adverse events. Can we request the creation of a new or revised measure term?
Oh, yes, absolutely. Every MedDRA subscriber, and that's you guys because you are on this webinar available to MedDRA subscribers. Every MedDRA subscriber is allowed, I think, up to 50 a month. So it's a very generous allowance of change requests per organization. And on our website, let's go to our website. On our main website, Help to Shape MedDRA Terminology, there is a link to our web-based change request tool. Now, I will caution you, though, that certain organizations will restrict who is able to submit these change requests because they want to be able to support them. So before you actually access the tool, and the tool does require a specific MedDRA username and password that is not the same as accessing your web-based browser. So please reach out to your organization if you have requests for new LLTs or changing the PTs or changing the hierarchy, moving the PT to a different HLT. These are all kind of different requests that you can submit for, but please reach out internally first to see if your organization has someone designated as the submitter and have that discussion with them. But yes, absolutely. And we do welcome all of those change requests. We do review each and every one of them.
Perfect. Our next question asks, how to handle reports of drug ineffectiveness that are reported at the beginning of therapy when it is expected that the drug is not going to take effect until 3 to 6 months into treatment?
Well, MedDRA does have a good selection of terms that speak to that. So you're talking about lack of effect, for example, right? So if you look up lack of effect and you want to see where does this reside in and how many other options I have, you right click it and you go to browser. So if you right click a term and you go to browser, it takes you to where that term is located in the hierarchy of MedDRA, and you can see all the different other types of terms that surround it that may be a better match to your scenario. So under the HLT, therapeutic and non-therapeutic responses, and it resides under HLGT, therapeutic and non-therapeutic effects. So there is assumption here of exposure to product, right? So in this group of HLT for therapeutic and non-therapeutic, you have a large group of options that you can sort through and decide if it's first a drug or is it a device? Is my product a drug or a device? And is it ineffective, or is it just ineffective for certain indication, or is it less than expected? And pick the one that best matches your scenario. Anything else?
Fantastic. Our next question asks, what are the shortcuts available in MedDRA which can be used for quick coding?
I'm not sure about what you mean by shortcuts, but one of the things that that we do recommend is, of course, putting as much of your source term in there as possible. So if I just put in effect, like when I put lack of effect, I got total results 4. If I just put in effect and I search, it's going to give me 344. So maybe one of the first approaches is try to get as much of your source verbatim that you received in its natural language from your reporter and use the STEM words and put in as many as you can. You can either do advanced search. So I'm going to show you in the web-based browser as well. Let's search filters. Navigation. Okay. And I'll show you also in the legacy one. If you're if you're getting a lot of results in your first go at it, and you want to limit the results, you can use these Boolean options. So you can use begins with if you want specifically that it begins with a certain word. So let me go back to basic search. For example, if I'm looking for seizure, and what MedDRA does is it automatically engages the synonym list. So I'm not just looking for, it's not just giving me seizure, it's also giving me epilepsy, it's also giving me anything with convulsant as a root in my search results. So I'm getting a large number of output, over 200. But if I know that I'm looking for a specific type and it begins with generalized, and I want it to contain specifically the word seizure, and then I search, that narrows down the results considerably. So there are a few shortcuts, if you want to call them that you can use the Boolean option. You can use as many STEM words as you can, and you can right click. You know, if you just click the term, you can see the hierarchy on the right hand side. But if you right click and go to browser, you can search surrounding terms to see if is there something better? Like these are the surrounding terms for epilepsy. Is there something better that matches my scenario? So yes, there are these kind of, and I hope that's what you meant by shortcuts. Any other question?
We have a question about the difference between the LLT drug overdose and just overdose, if you can talk about that.
Okay, so let's go to the browser. Let's go back to basic research and let's put overdose. So overdose itself has an exact match that goes to the PT overdose. When you look up drug overdose as a PT, it also goes to the same PT of overdose. So if you right click this PT and go to browser, just want to show you something. Here are all the LLTs that are housed under the PT overdose, whether it's acute or chronic, whether it's a drug overdose, whether it's multiple drug overdoses, whether it's a vaccine overdose. So the LLTs are intended to give you as much detail as possible. They are the most numerous terms in MedDRA. But the PTs are the ones used for, typically used for data reporting, data analysis, and data retrieval. So if your verbatim specifically states the word drug or medication, you can use an LLT that is the closest possible match to your verbatim by selecting drug overdose. If your verbatim does not have the word drug or medication in it and you just select overdose, you're being truer to your reported source verbatim. But either way, the two LLTs are going to show up under the same PT overdose, and you're going to be able to aggregate them. So some of the nuanced differences in MedDRA really speak only to the options available at the LLT level to try to be as close as possible to the reported verbatim, but they ultimately get aggregated at the PT level and onwards. Other questions, Hannah? Because I do want to get started with the coding exercises. Go ahead.
Yes, we had a follow-up come in about the shortcuts asking, can we use percentage symbol for shortcut?
Oh, that used to be in the past, and in the previous older versions of the browser, you had to use the percentile as a wildcard. You don't need that anymore. You just put in the stem word, and you don't need the percentile sign anymore.
Perfect. We'll do one more question for the moment. It asks, for the example, patient drank cranberry juice, which interacted with anticoagulant drug causing an INR increase. For this, the better LLT would be drug-food interaction? Is MedDRA going to update in upcoming versions?
So let's look up food interaction. And the drug-food interaction is non-current. So even though the LLT still exists in the browser, you'll see it has a red box next to it. And when it has a red box around it as an LLT, it means it's non-current. And if it's non-current, please don't use it for coding. It's there for legacy purposes. You can trace back previously coded data, but don't use it moving forward. And if you right-click the food interaction, you can see that the only LLT available under it is food interaction. So this is a non-current LLT. And if I right-click it and open the history, you can see when it was made non-current. Just give it a bit of time. It was made non-current in version 7. So it's been a while that it was made non-current. All right, so let's stop here and with the questions, and we can start the coding exercises. We want to do as many as we can. So here's another reminder of how you can access the poll EV. And this is the part that folks enjoy the most. So I'm going to try and give you as many exercises as we can, get through. And of course, we'll open up another Q&A session at the end, but please feel free to keep posting questions. And Hannah, please feel free to interrupt me if we have a lot of questions. Just a reminder, before you try to select the LLT that you think best matches the scenario, ask yourself, what is the information I'm getting? Because you want to capture the full extent of the information. You don't want to leave any significant information without selecting an LLT. So in some of these examples, you may need to select more than one LLT. Let's get started. Okay, man with decreased fertility. So man with decreased fertility. Okay, how would you select the best LLT match? And for these exercises, just because of the time constraint, we have provided you groups of LLTs that you can select from. But please feel free to actually go onto the browser if you like and do your own search. Especially when you're picking out the LLT, you may want to follow the hierarchy of the LLT just to make sure that it matches the area that you're interested in. So I'm just going to wait for a couple more responses and then we'll show. Let's stop at 40. Okay, let's show responses. All right, so fertility, decreased male. So man with decreased fertility, and the best LLT is fertility decreased male because it captures both the condition of decreased fertility as well as the gender of the person. So it is a male fertility decreased. The infertility is a bit of a different concept than decreased fertility. So infertility is complete lack of fertility. And the last one, the fertility decreased, does not capture the fact that the person was male. So yes, for this one, the best option is the fertility decreased male. It captures both the gender of the affected individual and the best match of the concept itself. Let's look at this one. Became colorblind in adolescence. Okay, so how would you pick this one? The best LLT for this one. Became colorblind in adolescence. And this might be a useful one to look within the browser. But let's see the responses coming in, and I'll stop in a little bit to give folks time to pick one. Okay, maybe this is enough numbers. Let's see the responses. All right, color blindness acquired, and you are correct. So I'm happy to see this. And the reason why we are picking the one with the COLOR spelling, even though both are the same, is because we're trying to match the spelling in the source verbatim. So MedDRA has spelling for American English as well as British English at the LLT level, and then PT level and higher is British English. So whatever the spelling that you have in your source verbatim, see if you can find the best match for it. It's a minor thing, but MedDRA has the option, so why not? And why do we pick acquired specifically? For this one, I think it's useful to take a look at the browser. And for some reason it froze, and I think it happened with another colleague of mine. Let's try again. Let me end the presentation, Hannah, and I'll restart because I think this happened with Carol Ann. And okay. Okay, so can you still see the screen with the browser?
Yes, I still see the browser.
Okay. So colorblind. So if we follow the colorblind, there's of course lexical variance with the blindness coming first, that's fine. But if we follow the hierarchy with the color blindness and the color blindness acquired, we're going to see a difference. You're going to see the first one, the first LLT, color blindness, without a qualifier, is linked to one PT because every LLT is only linked to one PT. And then the PT itself, color blindness, in this example, has two HLTs. It means it has two pathways, two hierarchies, while the one that's qualified as acquired only has the one. The difference is the following. MedDRA has a rule that if a condition can be both acquired and congenital, the one that is not qualified is the most common. We don't need to qualify it because it's the most common. So typically, color blindness is something you're born with. So typically, it's congenital. So the unqualified color blindness, that's why it has a dual link. It's linked both to the congenital system organ class as well as the eye disorders. And primary will be the congenital because that's a safety signal you want to enhance in your default settings. And by the way, the selection of which one is primary and secondary is hard-coded for you within the MedDRA files. Please don't change that even if you're able to. So the choice of which system organ class is primary versus which is secondary is something that the IMOs decide when they're adding new terms based on the rules of the primary system organ class allocation in MedDRA. You don't want to lose the signal of something being congenital. That's very important. Same for cancer and neoplasm, same for infections. So those three system organ classes, when they are part of multi-axial connection to the PT, take precedence. So in this case, the color blindness that is not qualified as acquired is the one that's more common, and the more common one is congenital, which is why it has the two links. But the one that is qualified as acquired only has the one link, which is the eye disorders. So I hope that that was a good example to show the hierarchy and why you want to chase the hierarchy when you're selecting it. Let me go back to my slideshow. Okay, and let me go take you back to the slide we were on. All right, so in this example, yes, the color blindness with the American spelling and the fact that it's acquired is the correct LLT. Let's do another one. Turned very greasy. All right, I do see responses coming in. And while the response is coming in, Hannah, do you have a question?
Yes, we had someone ask about adolescence in that colorblind example. And is there a way
Mhm.
to add it in, or if not, why is it not important enough to include?
That's a good question. Um, there are certain items that are out of scope in MedDRA, because if you imagine, if you want to add the qualifier of adolescence for every medical concept in MedDRA, that will hugely overpopulate MedDRA. One of the most important things the IMOs try to do is limit the overpopulation of MedDRA, especially at the preferred term level, because MedDRA is designed to chase safety signals and identify safety signals. And to have a clearer signal that is more enhanced, you want the base to be as limited as possible. We don't want MedDRA to be too large. That will dilute the signal. So certain things like demographic information, especially information that has typically its own field captured elsewhere, like if you think about age, age is a demographic field that's usually captured elsewhere. MedDRA will not capture the age for every specific medical concept. That will overpopulate MedDRA to an extreme extent. So no, adolescents, unless of course there are exceptions to every rule. So the exceptions would be if it is an important medical concept, like neonatal conditions. You're going to find neonatal conditions in MedDRA because that's an important medical concept. But adolescents typically, teenagers, preteens, early adults, those kind of demographics are not within the scope of MedDRA. But thank you for the question. All right, let's show responses for turned very greasy. And yes, you guys are correct. It is an unevaluable event because the word itself does not tell you whether this is something that happened to the patient or whether this is something that is not even a medical condition. So turned very greasy, the correct response is unevaluable event reflecting the ambiguous nature of the reported information. Here's another one. Patient experienced a medical problem. And I think you guys will know this one. So the patient experienced a medical problem. And maybe another question while the answers come in, Hannah?
Yes, we've had a question about off-label use. How should reports be handled when off-label use is not explicitly stated in the verbatim text, but it is clear that the product was administered by the HCP for an indication not included in the approved product information?
Okay, this is another one. I'm going to show you the PTC guideline. If it doesn't again, this happens again. So let me, unfortunately, stop the slideshow and, or maybe just show you the response to this, and then we'll tackle that question. Let me show you the responses to this question. Patient experienced a medical problem. So here's the responses. Ill-defined disorder. Thank you for that. Yes, and the reason why we chose an ill-defined disorder is because it has the word disorder in it. We know that there was a medical problem because that's what the source is telling us. And we know it has to do with a medical condition that the patient experienced. We just don't know what it is. So an ill-defined disorder is the best match. Remember, unevaluable event is an event that happened, something happened. You don't even know if it happened to the patient, if there was a medical problem with the patient. But in this example, it's specific. It's very clear that the patient experienced a medical problem. We just don't know what it is. So in this example, yes, the correct answer is ill-defined disorder. And unfortunately, let me also end the show here and show you under the PTC guideline. So we're talking about off-label. Maybe it's not hyphenated. Okay. Off-label use has its own section in the PTC guideline. So in terms of MedDRA selection, the PTC guideline says very specifically, only select it when off-label is specifically mentioned in the reported verbatim information. Now, we've had a lot of questions asking exactly what the requester has just submitted, saying, well, there are scenarios where you can almost tell from the story that this was an off-label use, but the words are not in the source verbatim. For now, the current PTC guideline says that it's specific to be used only when it's called out in the reported verbatim information. However, because that is a topic that comes back to us again and again with those kind of questions, I'm happy to say that the M1 PTC working group is discussing this very topic. So please stay tuned. Please come back to us in March when the new PTC guideline is released, because they will be addressing that particular question in the next version. Right now, I don't have the answer. I'm not part of the M1 PTC working group, but when the answer comes out, hopefully in the next release of the PTC guideline. For now, for the current coding practices, this is what the guidance says in the PTC guideline, which is the ICH endorsed guideline. Let me go back to this one and pick it up from here. Okay, so we were here. We said that the correct answer was the ill-defined disorder. And let's do another one. So the 2-year-old accidentally took his mother's medication. Which of these options do you think is the best fit for the verbatim? And you're trying to select an LLT that is as close as possible to the source. Sometimes the LLTs are sibling LLTs. They will take you to the same PT, so it's not going to impact your data reporting and data analysis, but you do want to always select the LLT that is the closest match to your verbatim. So let's take a quick look and see what kind of responses have come in. I think we have enough. Accidental drug intake by child. Yes, that is correct. You do have the word accidental in the verbatim. So even though the word unintended is synonymous with accidental, but you want to select the one that is the closest. You do know that it's a medication, so it's a drug. That's why we're not selecting product. And we do know that he took it. It's not the word ingested, but he took it. But as an FYI, all of these LLTs go to the same PT. So yes, you are correct. I'm very happy to see that. It is an accidental drug intake by child because that is the closest to the source verbatim. It captures what happened and as well as the demographic identity of the child. So in this particular example, we do have an LLT with the demographic information. Okay, this may be a simple one, infection after surgery. What do you guys think? Okay, I do see a lot of responses coming in. Let's see what the general thinking is. Yes, wow, very nice. Post-operative infection, because you don't have the word wound in your source, so you can't make assumptions that there was a wound. Very nice, guys. You're doing really well. Post-operative infection. This one is a tricky one. And I'll give you a hint. You're going to need the concept description for this one. He sold his father's medication. And as the answers come in, Hannah, maybe we can address one more question.
I am not seeing any pending questions at the moment.
Okay, awesome. All right, so he sold his father's medication is an unusual report to receive. And the biggest hint I can give you is please take a look at your concept descriptions. If you take a look at your concept descriptions, you may be able to answer this one and pick the right one. Okay, we have enough responses to see a general trend. Very nice. This is really very nice. Drug diversion. So drug diversion may not be a concept that's familiar to many people, but basically it's the unlawful use of a drug or diversion of a drug from its intended use. And I want to see if I can I go back to, I need to end it again. All right, so I don't know why it's happening this way, but every time I try to shift, it's freezing. But let me end this show and just show you what I'm talking about. So we said concept descriptions here, and look at the drug diversion. So drug diversion for purposes of coding in MedDRA means that a drug is diverted from legal and medically necessary use towards illegal use. It is illegal to sell somebody else's prescription medication. Well, what about a misuse? Can we say this was a misuse? Let's look it up. A misuse is the intentional use for a therapeutic purpose, either by a patient or consumer, other than prescribed or not in accordance with the authorized product information. So the key in the misuse is that it was for a therapeutic purpose. We have no clue what's happening with this medication being, sold for what purpose, but we do know that it was illegally sold because it was his father's medication. So in that example, and let me go back to the slide, you guys are correct. This is an example of drug diversion, which is maybe showcasing how helpful the concept descriptions could be. And like I said, they're a small group, so it is worthwhile taking a look at them. How about this one? Had MI. What do you guys think is the best option for this one? And let me go to here and sure it's active. And this may be like a tricky one, right? So it's just showcasing something else. I'm sure you guys know the purpose here. So yes, it is an evaluable event. This is great because MI is an ambiguous abbreviation. It has been made non-current in MedDRA. You can find MI in MedDRA with a red box around it. So don't use it for coding because it is an ambiguous abbreviation. So yes, the correct answer is unevaluable event. You guys are really doing really well. Okay, we showcased examples of this scenario. Hypernatremia with a serum sodium of 115 milliequivalents per liter. What do you guys think about this one? And the serum sodium typically is in the range of 135 to 145. So what do you guys think of hypernatremia with a serum sodium of 115 milliequivalents per liter? We have enough responses to show. Yes, this is really nice. Serum sodium abnormal is the winner because it is discrepant information. The first part of the report doesn't match the second part of the report, and we can't tell which one is the correct one and which one is not. So we don't know whether this is hypernatremia and they made a mistake in the numeric value, or whether in fact the serum sodium is low and they misspelled the hyponatremia. So the serum sodium abnormal is the correct answer. Great. Let's do a couple more if we can, and then maybe we'll open up in the last few minutes for any additional Q&A. She accidentally missed the morning dose. What do you guys think of this one? Which LLT do you think is the best match for this report that you've received? She accidentally missed her morning dose. Okay, let's see responses. And yes, this is really nice. She missed the dose in error. So we don't have the word accidental in our selection of LLTs, but we have in error, which matches the accidental nature of the event. And it's more specific than missed dose. So yes, this would be the best option. So like I said, it's not that the other options are completely wrong, but what is the best match of the LLT? Let's do another one. Here's a story where the doctor mistakenly prescribed the wrong drug. The pharmacist noticed the error and did not dispense the drug. So what do you guys think about this one? So there was an error because the doctor made an error, and it's clear that they're telling us something happened. But the drug, the wrong drug, never made it to the patient because the pharmacist noticed and did not dispense the drug. Let's see what you guys think. Oh, sorry, let me go back and just show responses. Intercepted drug prescribing error. And this is very interesting because, and let me just show you the correct answer. This is correct. I'm very happy with the selection. With the intercepted medications, the important thing to remember is that the intercepted error term should reflect the stage at which the error occurred. So this error occurred during the prescribing phase, and that's the one that was intercepted. So yes, there was a drug prescribing error. So we're capturing that information, but we're very specific that it was intercepted. So it is an intercepted drug prescribing error. I'm very happy that you guys picked that one. What about the next one, this next one? The patient reported a loss of smell and thought that she might have COVID-19 infection. She might have. So this is a provisional diagnosis. It's not a confirmed diagnosis. It's a provisional diagnosis. How would we approach this? She noticed a loss of smell and thought she might have a COVID-19 infection. I think we have enough responses to show. Yes, you guys are doing really great. Yes, you will capture both. You will capture the provisional diagnosis as well as any signs or symptoms reported. That's the preferred option. And notice that in MedDRA, the word suspected is used for COVID-19. It's not used in a lot of places. I mean, if you're ever curious and you look up the word suspected in our browser, you're not going to see a lot of them. Usually it's a qualifier that is not needed, like mild and severe, suspected and confirmed. But for COVID-19, it was found to be significant. And the reason we don't use anosmia, even though it's the same as loss of smell, is we're trying to be as close as possible to the verbatim. So that's very good, guys. You picked the right ones. Let's do one more. The dose taken was below the minimum recommended dose in the product label. What do you guys think of that one? If you keep getting everything right, we might have to submit a request to change these to harder examples because you guys are doing really, really well. So let's see what you guys think of this one. And I think we have enough to show responses. Underdose, yes, correct. So why do we pick the underdose? Again, to your concept descriptions, we said overdose was above the maximum recommended dose. Underdose is below the minimum recommended dose. So even though they didn't specifically tell you this was an underdose, they are giving you the exact description of an underdose. So yes, in this one, it was an underdose. And it doesn't specify within the context whether this underdose was accidental or not. So I can't assume it was accidental. I don't have enough context. So in this particular example, you guys are correct. This is an underdose. Let's do one more. This one is a little bit more complicated. The package medication contained too much drug, so the patient received an overdose and developed severe nausea and was diagnosed with gastritis. A lot of information here. What do you guys think about this one? So think about all the information you are receiving in this report. What exactly are you receiving? Are you receiving a medication error? If so, what kind? Are you receiving enough context to specify what type of overdose this was? Are you receiving contributing factor that you don't want to miss? Are you receiving any clinical sequelae? I see a lot of responses. So let me open this up. This is really nice. Okay, let's unpack this. The nausea is a typical sign and symptom of the gastritis. So we don't need the nausea separately. We have the gastritis because if we have sign and symptom that is consistent with the gastritis, the preferred option is just match the diagnosis. So that part is done, the clinical diagnosis, the clinical sequelae. What about the actual event that happened? What happened was an overdose, right? In the context, it explains how this overdose happened. So I have enough context to tell me that this was an accidental overdose. So I can select that one and be correct. But what about the contributing factor, this package of medication containing too much drug? I don't think MedDRA will have an exact verbatim to that, but MedDRA will have LLTs that speak to package volume issues. So this is a package volume issue or a package quantity issue. So it's important in this particular example to capture all the relevant pieces of the story. You had a contributing factor that led to the overdose. The contributing factor was the package volume overfill. You had an accidental overdose because the context explains to you the background of how this overdose happened. So it's not just a simple overdose. We know it's accidental, and it's one of those scenarios where the PTC encourages you to use the context. And we have the clinical sequelae. So in this particular example, to capture everything that was reported to us, we need more than one LLT, and we need to capture the clinical sequelae, the accidental overdose, and the contributing factor of how this happened. Let's do a couple more. I think we have a few more, maybe if time for a couple more. She was abused by her husband. What do you guys think of this one? She was abused by her husband. And again, you want to be as true as possible to your verbatim, to the source that you received. So we want to be very careful in our selection of the best LLT here. Which one best matches this scenario? I think we have enough. Okay, so we have kind of a split between spousal abuse and victim of spousal abuse. And even though it's a pain, but let me show you the differences between them in the browser. Let's put spouse and let's put abuse. Okay, so here's a spousal abuse, and here's victim of spousal abuse, and we even have spousal abuser. If we extend spousal abuse to see where it resides in MedDRA, we'll see it's under social circumstances. Victim of spousal abuse, if we extend that, we also see that it's in social circumstances. They're both under the same high-level group term of legal issues, but here's where they differ. In the HLT, in the high-level term, the victim of spousal abuse falls under crime victims, and spousal abuse falls under criminal activity. And if you right-click criminal activity and go to browser to see what other terms are captured in this HLT, you'll see things like child abuse, crime, elder abuse, imprisonment, homicide, sexual abuse. So these are all, if you want, the perpetrators of the abuse. And if we extend spousal abuser, it's under the same PT of spousal abuse. So this is a very important kind of illustration of how the hierarchy will guide you to which is the best selection. Even though they have the same SOC, the same HLGT, they differ by the HLT, and it takes you into a whole new world. So maybe a good reminder of please follow the hierarchy when you're selecting your LLT. Just make sure that it's the best one available to you, especially when you have multiple options in MedDRA. So let's go back and let's confirm that the correct response is victim of spousal abuse. Of course, we don't know if it's physical or verbal abuse, so we don't know that she was a battered wife. So that's why that was not the best option there. What about this one? The patient created a false belief that the relatives were stealing from her. So it's a false belief that the relatives were stealing. What do you guys think? Oh, let me activate. Sorry. What do you guys think of this one? It's active now. And this will be the last one because we only have 5 minutes left. I want to leave the last 5 minutes for questions. Okay, we have enough responses. Let's check responses. And yes, delusion of theft is correct. So there is no actual theft happening. It was her own false belief. So it was her delusion of theft. And yes, that is the correct answer. Okay, so let's wrap up with some MedDRA coding pearls. MedDRA is a dictionary that can be used to code more than one adverse events. It can be used for indications, post-op complications, social circumstances, surgeries, investigations, and so on. When you're coding in MedDRA, please try using the reporter's actual words in STEM words, like a few letters from the word, to expand your first look at the options. Be aware that MedDRA can be very specific, like we saw with that spousal abuse and victim of spousal abuse. So check the hierarchy, take a look at the siblings, sibling LLTs, siblings to the parent, PTs. Ensure that the location of the term in MedDRA matches your condition, like that color blindness, congenital versus acquired. You can try the top-down approach like we did in medication errors, going from the HLGT all the way down to see what kind of options we have, or the bottom-up, starting from the search field and looking at the LLT through its hierarchy. We can reach out to our colleagues who have maybe medical backgrounds. We can do online web searches, use medical dictionaries or lab range references in our review of terms. Boolean search advanced options are available to you if you get too many results. And of course, don't forget the MedDRA concept descriptions. There's always room for more and more training. So we discussed important advanced principles in coding. We discussed the MedDRA concept descriptions. We showed examples and hands-on exercises and summarized our presentation with some pearls. And these are the our contact information if you have questions, if you want to access the different browsers, and of course the training schedule and our support documentation. So we'll open it up now for Q&A, and I'm happy to stay on if we have a lot of questions, Hannah, although I know many folks will drop off. So do we have questions?
Yes, I believe our first question is referring to the example that was right before the spousal abuse example, and they're asking for clarification on why not nausea.
Is it the one with the gastritis? Okay, so the nausea, yeah, in gastritis, you have signs and symptoms. And if you remember, one of the advanced coding principles said that according to the PTC guideline, if you have signs and symptoms associated with a diagnosis, you don't need to code everything because it's not a provisional diagnosis, it's a definitive diagnosis. Of course, definitive diagnosis doesn't specifically say definitively diagnosed with gastritis. But in this example, the nausea is a sign and symptom typically associated with the gastritis. You don't need to capture it separately according to the PTC guideline. It's just enough to capture the diagnosis.
Next
any other
question asks, as spouse doesn't specify gender, would battered wife make more sense?
Well, we said that if you look at the options for this one, let me go back. So for the options for this one, the verbatim itself does not specify that this was physical abuse. So if this was a physical abuse, she was physically abused by her husband, you can choose battered wife. And at the risk of losing our place, let me show you. If we go to spousal abuse and right click and go to browser, It only has the LLT spousal abuse and spousal abuser. But if we go to victim of spousal abuse and go to browser, and we extend the LLTs, that's where battered wife is. So battered wife is an LLT subsumed under victim of spousal abuse. Only my verbatim did not specify that this was physical abuse. And as we know, there are different kinds of abuse. I mean, it could be verbal abuse, it could be financial abuse, it could be sexual abuse. So it didn't specify that, but that's a good question. Other questions?
Our next question asks, is there a tool for further exercising?
Absolutely. I mean, we have so many on our website. So let me end here. Okay. So in our website, let me go to MedDRA website. You see a link for the MedDRA Learning Management System. And if you click that, it takes you to our LMS. And our LMS has a, I don't know if I can log in or it's gonna, no, my account expired. So let me show you the catalog. There's a lot of modules available to you if you wanted to do your self-paced exercises. Some of these actually provide you with certificates when you're done, and some of these don't provide certificates when you're done. So if you're just interested in maybe doing some training at your own pace, you can pick the module that you like, and many of them have questions that you need to pass through to show or demonstrate understanding. So I think it's a very nice resource available to you. You just need to create an account. Any other questions?
Fantastic. It looks like that was our last question.
All right. Well, thank you everybody for your time today. It's always a pleasure to have you join us. We appreciate the time you spent with us today. If you have any questions afterwards, please feel free to submit them to our help desk. We'll be happy to get back to you. We wish you all a pleasant rest of your day today. Thank you.